Dr. Edward.
Monitoring is the backbone of anesthesia management, be it in the OT or in the ICU. So now, in this session, let us learn more about the newer methods of monitoring. We would like to welcome Dr. S.V. Goodley, sir, to chair the session. Dr. S.V. Goodley is presently working as professor and head of Department of Anesthesiology at Belgaum Institute of Medical Sciences, Belgavi. Fields of interest include labor analgesia. I would also like to welcome Dr. Raghunath Aladakatti. He is head critical care consultant, intensivist at Gopal Gowda Shantaveri Memorial Hospital, Mysore. We request to introduce the speakers, sir, please.
I thank organizing committee for giving this opportunity. I very happy to introduce a guru of mechanical ventilation, Dr. T.R. Chandrashekar, also my guru. Sir, teaching mechanical ventilation since so many years, more than I think 15 years, sir. Sir is intensivist, liver transplantation, Institute of Gastroenterology, Science and Organ Transplant, Bengaluru, Karnataka. Sir has written textbook on mechanical ventilation. I think we are all using Sir's Scalars. Scalars are the most important monitoring aspects when it comes to the mechanical ventilated patients, because Scalars tells about the lungs characteristics. Before STET, before ultrasound, before X-ray, we can know the condition of the lungs by seeing Scalars. I request Dr. Sir T.R. Chandrashekar sir to continue the talk.
Good evening. I said good evening. Okay. So, thank you, Raghunath. He's a good friend of mine, and for his kind words. And I would like to thank the organizers for giving me this opportunity. So, at the fag end of the day, I'll try to make it a bit short and interactive. So, my topic is about ventilator Scalars. So, how do you monitor a ventilated patient? You should never try to underestimate the power of clinical science. Nowadays, I see it has become kind of the younger crowd is feeling that touching a patient is a crime. They always go with all the fancy echocardiography, ultrasounds and all. They just even don't try to look at the sides of the chest, which sometimes tells you obviously there is a pneumothorax or a collapse. So don't underestimate. These are obvious. These are the things which we always put it. And one thing is, when we talk of Scalars, it is obvious that the patient is already on a ventilator, right? So then only the question of Scalars are possible also on a non-invasive ventilator, but most of the studies have been done on mechanical intubated patients with mechanical ventilation, and the same apply for non-invasive ventilation also. So using a ventilator as a probe of physiology to monitor respiratory mechanics is what is the talk about, and it gives the assessment of mechanics and provides an insight into the pathophysiology of the lung, and it's real time, meaning, and that is to provide a lung protective ventilation. I'm going to tell what it is. So if you have a comparison between a lung ultrasound and a lung ventilator graphics, it's a real time. You can see every minute whenever a tidal volume goes and interacts with the alveoli. When they interact, the output that you get is displayed as graphics. So it is a real time. Every breath which is delivered interacts with the airways, with the alveoli, and it's displayed on the ventilator. Minute to minute, there is a kind of a output, and you can analyze that and do the settings accordingly and see to it that the patient is in the lung protective zone. So one thing all of you have to remember is ventilator does only one thing. It has been made into such a complicated thing that people think it's a very complicated equipment. No, ventilator does only one thing. It just produces an inspiratory flow of gas. It just produces an inspiratory flow of gas. Whatever you set, it just gives a flow of gas. And it is obvious, isn't it? We have been taught that anything to move from one to the other, there has to be a pressure difference or a height difference. If somebody throws water from there, it will come here. But if somebody puts water, it's not going to go up. So there has to be a pressure difference, which normally we create by a diaphragmatic movement and a negative inspiratory pressure. But when you put on a ventilator, the pressure is created in the mouth positively and the air is pushed in. So what is the relation between volume and flow? Both are same. How both are same? See here. If I have a bucket of bucket with a flow, and if I fill the bucket for 1 minute, and if I fill the bucket with 2 minutes, what is the flow? What is the volume I have collected? It is double. So flow, when you look in the context of time, becomes volume. Both are same. A flow in the context of time is volume. So the purpose of mechanical ventilation is to put a tidal volume into the alveoli. And this I have already told. When you put volume into a closed space, because alveoli is a cul-de-sac, when you put volume into a cul-de-sac, what increases? What increases? Pressure. So there are three components that I have introduced now. One, there is a flow. Flow for a given time is volume. And volume in a closed space is? Those are the three components when we plot against the time are called scalars. If I go and directly tell there is a flow scalar, there is a volume scalar, you will think how? Where did it come from? So this is the science behind it. Ventilator produces just what? Respiratory, inspiratory flow of gas. And a inspiratory flow of gas in the context of time becomes? And volume in a closed space produces? So when you plot all the three against time, we call them as scalars. So what are the three scalars we have? Yes. Right, these are the three things. When you plot flow, volume and pressure on the vertical axis, time on the horizontal axis, we call it as flow versus time scalar, volume versus time scalar, and pressure versus time scalar. And there are two loops. That's not my topic. I'll not look into it. See, always the scalars start from one point and always goes towards the right of the screen. And whenever you see here, a representation below the baseline, that is always a flow scalar. Whenever you see a scalar with a base representation below the baseline, you can always be sure it's a flow versus time scalar. And those are the things that you can find out. I'll just look into it. This is how it looks on the screen. Which is the flow scalar in this? The lower one? Yeah. See, seeing anywhere, you can find out what are the scalars. And when I talk of scalars, what you have to understand is, when we are talking of flow, so this will be not pressure or volume, so it has to be flow. This is peak inspiratory flow, and this should be the. So when you are talking of flow scalar, everything is flow. And this is the time, inspiratory time. On the time scale, you should look at as inspiratory time, expiratory time, cycle time. In this scale, if you are looking at this scale, it is always flows. In this scale, it is always time. And what can you find out? This is something you can find out. This is the normal one, and this is the abnormal one. What is happening? The expiratory limb is not coming to the baseline and the inspiration is starting. So what is staying back in the lung? So what is it called? Autopeep or dynamic hyperinflation. Okay. And what is that? You commonly see that. That is because of probably secretions or some water particles. Because air is getting hit by water particles, so there is a oscillation. When you put a humidification, so it can also look like that. So modes also you can find out looking at the. So just a quick word about this. This is always a square wave is a volume controlled, and a decelerating with the time touching, it's pressure controlled, and a decelerating starting much above the baseline is pressure support. I don't have time to teach you this. So whenever you see standing from a distance, if it's a square wave, it is volume controlled. If it is a decelerating, touching the time, then it is time cycled, it is pressure controlled. And if it is happening much below, it is a flow cycled one. It's a pressure support mode. The next 4-5 slides are very important. That is where the lung protective ventilation come into play. If you want to learn scalars, I would say that those are the 4 slides of the scalars you should remember to produce a lung protective ventilation even in anesthesia and in critical care or in a ICU practice. So when we come into a pressure versus time, so this has to be now pressure, it can't be flow. So this is the peak inspiratory pressure. And the base pressure is called, what is that pressure? That's already there. It's the PEEP. See, these are the 4 pressures that you should be aware of. See, whenever you set anything, it goes and reacts with the alveoli, right? And it produces, I have said, when you put tidal volume into a closed space, what rises? So what are the 4 pressures we should know? See, 2 pressures are already there. Whether you put, whether when you intubate, what are the 2 pressures which are already displayed? Peak and, so how do you get these 2 pressures? So there is a peak pressure. So what contributed to the peak pressure? So the air has gone through what all? What all it goes through? It goes through stomach, then airways, then alveoli, and there is a chest wall. So 3 things are contributing to the PIP. So how to discriminate what is contributing how much is the next question, right? So once you understand that, you know what to change in a ventilator. So these are the 3 things, right? These are the 3 things. Now you can put in a button called as, this is called the inspiratory hold. That is the most important button on your ventilator. You just put it for 3 seconds, you get what is called as plateau pressure. Okay, I am more comfortable now. So this is the most important button. We have got a plateau pressure. Now what has been eliminated? See, I put it here. The difference between these 2 is trans airway pressure. Once you get a plateau pressure, it is only contributed by chest wall and lung. And it is very difficult to discriminate how much is being contributed. You require an esophageal balloon. But obviously you can clinically identify what is the contribution of a chest wall. See, for example, you are operating a laparoscopy. Somebody puts pneumoperitoneum. The peak pressure goes up. What should be the cause? Chest wall. Right? So it is clinically done. But if you want to really do it, you have to put a esophageal balloon. Even in critical care, we don't put it to every patient. And do we always have a normal lungs in patients we anesthetize? See, we may have a patient who comes with a bowel perforation and already not saturating well, mild sepsis, isn't it? So producing a lung protective ventilation is always required even in ICU, and you may start with a normal lung, patient may develop a trolley. So the lung may become sick. So you should know what are the lung protective boundaries. See, these are the boundaries. See, whatever setting you do. See, normally these books say that we should maintain the P flat of 16 and at driving pressure. The driving pressure is the difference between the P flat and P. Should be around 13 for a normal lung. So how did we get this P flat? Which button did we press? Inspiratory on a volume controlled in a passive patient for 2 to 3 seconds. And this is the for ARDS patient. So our boundary starts from 16 to 28, 13 to 15. This is where we have to keep the pressures so that we are in the lung protective zone. Even why somebody may ask, why should this be done in a normal lung? Because studies have shown that post-pulmonary complications are very, very high if you cross these pressures. And one most important parameter that you have to maintain is maintain the tidal volume of 6 to 7 ml for the ideal body weight. That is the starting point. Then you have to fine tune with looking at the P flat and driving pressure. That's how you set the tidal volumes. So just one case. I think I have a minute more. Because how do I practice lung protective ventilation? Just 2 more slides. So always, how do you practice? One is always measure patient's height. See, remember, if somebody is 5 feet and if he is 50 kgs and somebody is 100 kgs, your lung doesn't double in size. Yes or no? So there should be a practice of measuring height and calculating the predicted or ideal body weight. And for that you should set how many ml? 6 to 7 ml. That is the starting point. Then immediately after intubation, we already have 2 values and we measure these 2 values. So by doing what? Which button? I have been shouting so much. All of you can, inspiratory hold in a passive patient, because most of your patients are passive in anesthesia and in a volume controlled. Okay. Any change in PIP, always go back and look, and any change in PIP, SpO2, EtCO2, again check. One case to see how I have driven home my point. A 75-year-old patient posted for fracture neck femur surgery wants GA. This guy wants GA. So that's the indication, right? That's the indication. DM, hypertension, because I don't want a controversy, because all of you will say we'll put a regional. So then I can't go ahead with the case, right? DM, hypertension, ISD, COPD, EF is 38. So there is trouble, isn't it? We are heading to trouble. So first, I have done a lung protective ventilation. What is my PIP? Okay. Now, a problem occurs after 1 hour. So what is the problem? What should I see now? Which button should I press now? Inspiratory hold. Okay, I press the inspiratory hold. I get a reading like this. So what is the problem with this patient? What is the problem with that patient? See what has happened here. P flat is 16. PIP is 28. So what is the difference? So 12 is contributed by what? Contributed by lung or airway? So patient has developed. There what has happened? What is the trans-airway pressure? Just 3. So what has happened? Right. So there is no problem either way, because every anesthetist, when there is a saturation problem, there is a cocktail. Lasix, steroid and a bronchodilator. So it has covered everything, no? There's a common cocktail in the ICU also. But that's not the way you do, because I have taught you to differentiate between bronchospasm and a alveolar problem. Airway problem and alveolar problem. But obviously, if somebody in a laparoscopy has a situation like that, then you should account it for chest wall problem. And you should increase the PEEP. Thank you.